Welcome to our webinar titled Ask the Expert, a Q&A with Dr. Elizabeth Griffiths. Thank you for joining us today. My name is Lee Clark, patient educator, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of Alexion and Apellis and our patients, families, and caregivers for supporting the webinar program today. Due to the high volume of teleconferences on the internet, it is possible you may lose your connection during the program. If you are unable to view the webinar online, please use the call-in number in your reminder email to hear the audio portion of the program. The webinar program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions or comments at any time using the Q&A window in the lower part of your screen. Just type in your question and hit enter, and we'll do our best to get to everyone's questions today. When asking questions, I do ask that you do 2 things to help me moderate the incoming questions. First, please submit your question all at the same time. Second, please do not share any private health information in your question. Our speaker cannot answer any specific questions related to your health care. Today's specialist is Dr. Elizabeth Griffiths. She is an associate professor, the director of MDS and clinical disease team leader at Roswell Park Comprehensive Cancer Center. She is board certified in hematology, oncology, and internal medicine. With that said, welcome, Dr. Griffiths.
Thank you for having me.
Thank you so much for joining us today. What is PNH?
So, as I'm sure many of the listeners are already aware, PNH, or paroxysmal nocturnal hemoglobinuria, is a blood disorder characterized by intravascular hemolysis, or breaking of red cells inside the circulation, which results in continuous destruction of normal red cells or of abnormal red cells, and increases filtration of free hemoglobin at the kidney. So in the old days, people were identified because they showed up in the morning with sort of darker urine, and it was felt to be paroxysmal because there were associations with exposure or stress events which increased the level of hemolysis. We now understand that this is a stem cell disorder and is seen very commonly in people who have an immune attack on the bone marrow. So most people who have PNH will have some kind of cytopenia, some low blood count, usually anemia, but often also low platelet counts and low white cell counts as well. And almost invariably, these low blood counts are mediated by some form of immune attack against the bone marrow stem cell compartment. Under normal circumstances, human beings are born with a cadre of stem cells. Those stem cells are born with us, they live with us our whole life, and they act like a factory. So all of us, every single day, our bone marrows are working for us. They make all new red cells every 3 months. They make all new platelets every 7 days or so. And they make all new white cells every 7 to 10 days, all new neutrophils. Those are the important infection-fighting foot soldiers that protect us from standard bacterial infection. There are other components of the immune system as well, including T cells and B cells. Those are a bit more complicated, and it's the T cells that we think are actually damaging the stem cells in our bodies when people have PNH. But when you start to develop, you can develop accidentally or as a result of a viral exposure. We really don't understand the mechanism. One can develop a T cell clone. T cells are kind of the directors of the immune system under normal circumstances, but they can also attack and kill our own cells. Many people are familiar with the idea of an autoimmune disease in the form of lupus or of rheumatoid arthritis, where people get arthritis or attack of the immune system against joints. But fewer people are familiar with the idea that those same kind of T cells can actually attack our bone marrow stem cells. And when that happens, the bone marrow stem cell compartment can be diminished in terms of size. And sometimes, as a result of a mistake in the cell division, some of the stem cells can escape the attack because they downregulate expression of protein on the cell surface. So it's almost as though that stem cell compartment, some cells can expand, which are undercover because they have less flags flying on their surface. Those stem cells are actually protected relatively in the bone marrow environment, but they are less, but their children, the product of those stem cells, are missing certain important flags on the cell surface, which protect them from attack by an older part of the immune system called the complement system. Is that too complicated? I don't know if that's too complicated, but the idea is that a T-cell mediated attack on the bone marrow results in expansion of a clone of relatively protected bone marrow stem cells that are missing surface protein. That population is protected in the bone marrow environment, but is more susceptible to attack by the complement system in circulation. And so what happens is this bone marrow compartment of this stem cell pool of cells that are missing protein on the surface, we call them PNH cells. Those cells expand in the bone marrow environment. They get born into circulation. And when they're born, they produce red cells, white cells, and platelets that can be attacked by an old part of the immune system called complement. Complement is designed to protect us from invading bacteria, and it works by punching holes in cells that are not recognized by the immune system. So normally all of our cells have a handshake mechanism. They go out into the world of the circulation and they interact with the rest of the immune system by flying flags. The flags say, I'm okay, I'm a friendly guy, I'm not a problem. If you're missing those flags on the surface, the immune system can erroneously think that you're an invader and can attack you. And so that's what happens in PNH. The PNH stem cell is protected in the environment of the bone marrow against attack by the T cells. But when they're born into circulation, the progeny of that stem cell are missing the flags on the surface that tell the old part of the immune system that those things are safe. And so the result is that the complement system punches holes in the red cells and kills them while they're in circulation. And so PNH red cells have a shorter life expectancy compared with normal red cells. You might remember I told you normal red cells, those get replaced every about 3 months. If you make a PNH red cell, depending on how bad or how few flags that cell has on the surface, it might last as few as 10 to 15 days, or maybe as long as 30 days, but it doesn't last the full 3 months that a normal red cell would last. And so the result is that people are anemic. They might feel short of breath, they might feel tired, and they have this continuous killing of new red cells, the newly produced red cells all the time, which releases hemoglobin into circulation. That can damage the kidney because free hemoglobin poisons the kidney a little bit. It can also cause scavenging, or the free hemoglobin binds to, normally it binds oxygen, right? Hemoglobin. But free hemoglobin also binds other molecules, including a molecule that's really important called nitric oxide. Nitric oxide is familiar to people because of Viagra. We take Viagra to increase erectile turgor, and what that does is it actually releases nitric oxide, causing vasodilation. But if you don't have enough nitric oxide, that you can get vasoconstriction, and that can happen in the lungs, can happen in the penis to prevent erections, and it can happen in other organs, and can increase the risk of strokes, can create pulmonary hypertension or increased blood pressure in the lung, and can cause acute kidney injury.
Thank you. You had mentioned the term clone. What are clones, and what does it mean if a patient is told that they have their clone size is high? Yeah.
So think about the bone marrow as being made up of all these different seeds, right? When you're born, you have the maximum number of seeds. We don't know what the total number is of people who, when they're born, but the maximum number that you have, many hundreds, probably many thousands. Over the course of life, the numbers of those stem cells, the number of those stem cell seeds decreases by about 1% per year. Each of those seeds could be called a clone. They're each capable of producing red cells, white cells, and platelets. When they start to grow up, ideally, one of them stays a stem cell or a seed, and the other, after division, grows up to produce different types of progenitors, red cells, white cells, platelets, T cells maybe. You can imagine that all the children of that one seed share the same genetic material. If that stem cell develops a mistake, all the children of that stem cell will have the same mistake. When we think about PNH as a clonal disorder, what we mean is that there are particular stem cells that have developed a mistake. Again, that mistake is protective in the bone marrow, but increases the risk of getting killed by the old immune system in circulation. And that clone is the cell with the PNH mistake. And so when we think about that clone, the question is how much of the production from the bone marrow is from cells that are having that mistake. So normally, only 1 or 2 or 3 or 4 stem cells would be producing the cells at any given time because they share the work, right? So they don't get tired. Sometimes if you've got PNH or you've got an aplastic anemia or you've got a bone marrow attack, the amount of stem cells that are functional or that can do the job is diminished. And so those stem cells with the mistakes become the dominant players in the bone marrow production realm. And so when we look in the peripheral blood, we can actually measure what percentage of the cells are missing those proteins on the cell surface. And we say that's the size of the clone or the size of the dominant clone. And what we mean is how much of the total bone marrow is deficient in PNH cells. And we use the red cells. Remember I told you those guys get killed really aggressively by the old part of the immune system. The clone produces not just red cells, but also platelets, monocytes, and neutrophils. Those are the other kind of cells that can grow from bone marrow stem cells. And one would expect an equal percentage of cells in the blood of red cells, monocytes, and neutrophils resulting from one stem cell, right? They would all produce relatively equal amounts of those 3 different types of cells. What we see in people with PNH who are not on therapy is that the red cell size is often very small compared with the monocyte and the neutrophil size. And what that means is that the red cells are being aggressively killed, whereas the monocytes and the neutrophils, which have extra ways of protecting themselves from killing by the old part of the immune system, they can survive. So when we look at a PNH report, it usually reports what is the clone size, and it usually reports clone size of monocytes and also neutrophils and then the red cell. And so you can imagine that the biggest clone size you would see would be in the monocyte or the neutrophil lineage, and that the red cell clone might be smaller. And that again reflects the killing of the red cell compared with the white cell. Does that make sense?
Mm-hmm. Thank you. Do we know what causes PNH?
So we don't know for sure, but we see PNH in people with underlying bone marrow problems, more frequently people with aplastic anemia, which we think is happening because of a T cell attack. Remember I told you it's like an autoimmune disease. We think that what happens is somehow one of the T cells in our body, which should actually be going out and searching for bacterial and viral infections and protecting us from cancer, by mistake attacks a bone marrow stem cell and starts to like eating bone marrow stem cells. We also see PNH clones arise in people with myelodysplastic syndrome, or MDS, which is another bone marrow failure disorder. But usually it's also in the context of disease, MDS disease, which is relatively hypocellular in the marrow, and often potentially an immune-mediated attack on the bone marrow. And so the hypothesis or the idea of aplastic anemia and PNH is that because there is a T cell attack on the bone marrow, those PNH clonal cells are relatively protected because they have less surface protein, and they express less stuff on the surface. So they're kind of undercover. They don't get seen as well by the T cells, which depend upon recognition through protein interaction. So the T cell has to shake the hand of something and see that it's abnormal and sort of say, I'm going to eat you. In PNH, we think that those T cells are erroneously attacking the normal bone marrow stem cells, allowing that PNH clone to expand, which is relatively protected. That's what we think.
Is PNH hereditary?
No, PNH is not felt to be hereditary. This is an acquired stem cell disorder that occurs in the context of an acquired immune-mediated attack on the bone marrow.
Okay. And You had mentioned about PNH and overlapping diseases such as aplastic anemia and MDS. Does having a dual diagnosis complicate the PNH diagnosis?
So it can complicate a PNH diagnosis because it can make it hard to know what's the cause of the low blood counts, right? So when we have patients who present with low blood counts, you have to decide, is the problem because there are just too few stem cells? Or is it because there is excessive killing of the PNH cells by the immune system in the peripheral blood? And so one of the ways we figure this out is by looking in the bone marrow and asking the question, is the bone marrow cellular or hypocellular? And also looking to see how low are the blood counts. In many patients, there's two factors going on. There's both PNH disease, which is at a large level and is causing clear evidence of hemolysis that is contributing to the anemia and potentially the thrombocytopenia. But there is also a bone marrow failure problem with inadequate stem cell production. And so if you have two situations, sometimes I treat both at the same time, and the treatments are a little bit different, right? For aplastic anemia, the general approach is actually immunosuppression. And the idea there is to kill the T cells that are attacking the bone marrow. In general, the approach to treatment of patients with aplastic anemia is largely dependent on age. So the younger you are, the more often we offer bone marrow transplant as our sort of first choice. If you're above the age of 40, our general approach first line is to think about immunosuppression with 3 different drugs. We give a drug called ATG, or anti-thymocyte globulin, most commonly horse anti-thymocyte globulin. And what we do to get the antibodies, we take human lymphocytes and we give them to a horse. We essentially immunize the horse with human lymphocytes, and we collect the plasma of the horse, which we call antisera, and we give that to people, and that kills the human T cells, and so depletes the human T cells. In combination with that horse ATG, we also give a drug often called cyclosporin. Cyclosporin is another pill drug that kills T cells and prevents them from expanding. So you do a big job of killing them with the anti-thymocyte globulin, and then you follow that up with a T cell growth inhibitor, which prevents those T cells from rapidly growing back. And then as a recent addition to our approach, we have added a stem cell support drug called eltrombopag. Eltrombopag is a really interesting, very small molecule that is a copy of a hormone that we all make intrinsically in the liver called thrombopoietin. And probably one of the reasons why people have slow recovery of blood counts after you give immunosuppression is because the stem cells have been taking such a hit from the immune system that they're a little bit pokey, and they're a little bit, they're sort of inhibited in their willingness to come back because they're afraid they're going to get hit again. And the eltrombopag binds inside the thrombopoietin receptor and encourages that stem cell pool to come back and grow back. So that combination of 3 drugs has proven exceedingly effective for aplastic anemia, published in the New England Journal of Medicine in 2017 by the group at the NIH, showed really nice responses in people with aplastic anemia, even older people with response rates as high as 60 or 70%. So that's sort of the standard approach that we now use for people who are not immediately transplant eligible. And I would say that if you have a PNH clone that's relatively small and you have low blood counts, my first approach is kind of to treat the aplastic anemia. In order to make a diagnosis of aplastic anemia, you need a few things. You need to show that the bone marrow is hypocellular for age. You need to show an inadequate reticulocytosis, so young red cells in the peripheral blood that are low. So that shows that the bone marrow is not doing its job to make new cells. And generally, you need to show a neutrophil count or an infection-fighting foot soldier count that's also low. We grade aplastic anemia based on severity, based on the depth of the low blood counts and the cellularity of the bone marrow. And we say that people who have severe or very severe aplastic anemia, as defined by the neutrophil count, would warrant immediate treatment with immunosuppression. Sometimes you can see a large PNH clone in addition to that, but more often what I see is a very tiny PNH clone, 1 or less than 1%, in patients who have bone marrow failure with a profoundly hypoplastic bone marrow. And then we treat those people with immunosuppression. And what you sometimes see is after you treat with immunosuppression, you can see emergence of the clone, because now you've removed that T cell attack. That clone has a relative survival advantage because it was not killed as aggressively by the immune system. And so you can see sometimes the emergence or the increase in the size of the PNH clone in people who've received immunosuppression for their aplastic anemia. And so routinely what I do is I always check people for a PNH clone when they show up with bone marrow failure, and I make a diagnosis of aplastic anemia. And then I recheck again after they've received treatment. There are two reasons that I check like that. One is that the presence of a PNH clone in a person with a new diagnosis of aplastic anemia talks to me about the mechanism of the disease being mediated by the T cells and predicts a really good response, better than 90% response to that immunosuppression approach. And second, I want to make sure that I follow that over time, because if that emerges and becomes a large population of cells, 20, 30, 50, I have some patients who have more than 90% of their hematopoiesis is coming from stem cells that are missing the PNH gene. And so they don't present as much stuff on the surface. And so their red cells are very susceptible to attack by the immune system. So if you have patients with 90% PNH clones, those people are often very symptomatic. They have a lot of belly pain, they have shortness of breath, they have a profound anemia, they need transfusions. And so I usually follow that PNH clone at the baseline when I have a patient who comes in with a new diagnosis of aplastic anemia, and then at the 3-month time point, and then I do it again if at the 6-month time points when the counts are coming up. Once somebody has good count recovery after they've received treatment for aplastic anemia, I usually follow the PNH clone about once a year, unless somebody has a new symptom, a new blood clot, new shortness of breath, new belly pain, something that would make me worry. I also follow the LDH over time, because the LDH correlates strongly with hemolysis or red cell destruction. And so it can be a marker for increased activity of the PNH cells.
Thank you. And this may be just a little bit of a follow-up. We have a question that says, how often do PNH patients need to have a bone marrow biopsy or PNH testing? And can biopsies change in appearance over time?
Yeah, so when I have patients who have PNH, if they have stable counts and they're sort of stable on their treatment and they haven't had a problem, as long as the blood counts are stable, I generally do a baseline bone marrow, and I wouldn't repeat it unless somebody has a change in their blood counts or something new happening, something that makes me worry. Some patients get more often if they had any concerning features. So, these days we sometimes do molecular testing on people. Certainly for MDS patients and people with AML, we do molecular testing as a matter of course. That's not so true for the aplastic anemia population, although sometimes when you're doing the initial assessment, you don't know what's going on. And so in my experience, most people with aplastic anemia do not have mutations that I identify when I do mutation testing on the bone marrow. If I had a patient who had mutational events when I first did the bone marrow, even though they had aplastic anemia, I might be more inclined to be worried about the possibility that something more sinister might emerge, like a myelodysplastic syndrome or an AML. And in that case, I might consider doing a bone marrow biopsy more often, or maybe once a year, just to make sure that things were not changing. But in a general case, if I have a standard patient who has PNH, standard PNH, their counts are stable, they're on appropriate therapy, they're doing well, I wouldn't do another bone marrow biopsy other than the one at the time of diagnosis, unless their blood counts changed substantially.
Thank you. What are the current treatment options for PNH?
Yeah, so for people with clinical hemolysis, that is to say for people who are anemic, who have an elevated LDH, or who have symptoms of intravascular hemolysis as manifested by kidney dysfunction, pulmonary hypertension, shortness of breath, or blood clots. We haven't talked a lot about blood clots this time, but blood clots are the primary problem that people with PNH have that adversely affects life expectancy. Many patients with PNH are identified because they show up with a blood clot in an abnormal spot, like blood clots in the venous sinus of the brain or in the liver. Those people warrant treatment with an inhibitor of the complement system. So remember I told you before, the PNH cells are subject to killing in circulation, by an old part of the immune system called the complement system. So complement is a system of proteins whose job it is to identify invaders that are lacking markers on the cell surface and to drive holes in those invaders. Once the complement system gets activated, it cleaves a whole series of proteins in a cascade, and the final common pathway of the complement system is essentially the production of a series of little proteins that all stick together and form like a little pore. And actually you can take pictures of the red cells from people with PNH and you can see a little ring of proteins all in a circle that make a little pore. And those pores, normally our cells are separated from our circulation, separated from the environment by a lipid membrane. And that lipid membrane keeps inside contents on one side and outside contents on the other. Cells are full of stuff. And if you make a hole that allows water to pass freely, water will rush in through that hole. And it'll actually cause swelling of any cell that is opened like that. And it'll cause swelling and actually bursting of that cell because water is trying to go in and equalize itself in terms of the number of molecules on each side of the membrane. You guys may remember from school the idea of oncotic pressure. And that's exactly, do you remember from school, you have to have a semi-permeable membrane on one side, you have stuff, and on the other side you have nothing. And if you put stuff on this side and you have a semi-permeable membrane, the water will rush to go to the side with stuff, right? Because it wants to equalize itself in terms of the distribution of stuff. It doesn't like there not to be an equal amount of stuff on each side, and so the water is trying to dilute those bits out. So that process of oncotic pressure can actually be very powerful in small cells. And that is the mechanism by which the complement system bursts red cells in PNH. It also does the same thing. The same process happens on the platelet and also on the monocytes and the neutrophils, but those cells actually will do something called blebbing of their membrane, where they actually squeeze off a piece of the membrane. They'll just cut it off and let the little piece go, and that thereby protect themselves from killing. So very interestingly, the complement system requires, as I said before, a whole series of activation of different molecules. And one of the most important of those molecules, there are actually two different spots where you can intervene there, is C5. And there's an earlier part of the cascade, it kind of goes C1, C2, C3, C4, C5. An earlier molecule is called C3. So if you block those little proteins from interacting with each other and cutting each other, you can block that final common pathway of hole making. And by doing that, you can actually allow those PNH cells that are missing the proteins on the surface to survive longer. And so the treatments that we have for PNH are actually treatments that block that process of complement activation. And we knew actually earlier on that this approach might be safe because there are actually human beings who are born with complement mutations that result in a loss of terminal complement activation. And those people usually do fine, except that they have an increased risk of infections with encapsulated bacteria, particularly meningococcal bacteria, okay? Meningococci are actually little spheres, they're candy coated, and the way that we kill them most effectively are by doing that hole punching process. But we knew that those people survived reasonably well, and so it was based on that observation that people started to develop antibodies, monoclonal antibodies that could bind to and inhibit the function of that enzyme C5, and recently a similar approach blocking C3. And so there are two different approaches. One of them is the drugs eculizumab and ravulizumab, both of which block C5, and the other one is the drug APL-246, which blocks C3.
Thank you. Why would bilirubin be high in a patient with PNH?
So bilirubin is a molecule that we see in the blood, which is a breakdown product of the red cell, of heme. So normally, heme, which is the building block for hemoglobin, is the molecule that we use inside of our red cells to carry oxygen. Heme binds the heme molecule binds 4 molecules of oxygen and changes shape depending on how much oxygen is in the space around it. When it changes shape, it releases oxygen. So it binds oxygen. When there's lots of oxygen around, heme binds to 4 molecules of oxygen. When heme goes into a place where there's not very much oxygen, it changes shape and releases those molecules. When heme gets broken down, it gets transitioned by the body in the liver to something called bilirubin. And so if you have an increased turnover of your red cells and you have increased release of hemoglobin, the bilirubin will go up because you will see the breakdown. That's the process by which we break down hemoglobin.
Thank you.
There are 2 different types of bilirubin. I just want to comment on that. There are 2 different types of bilirubin. Bilirubin can be conjugated or unconjugated. Conjugated means you add a molecule to it to make it more water soluble. The liver actually does that. So we often see people who have intravascular hemolysis have an increase in unconjugated bilirubin. And people with liver disease, you can sometimes see an increase in conjugated bilirubin.
And is there a treatment for that, for lowering your bilirubin?
So one can use a drug called ursodeoxycholic to increase flux of bilirubin through the GI tract. You can use bile acid binding resins, which actually bind bile, which is made in the gallbladder, is made from bilirubin, and it's part of what you use to solubilize fat. This is probably more than people want to hear, but it's an important part of the system, and you can actually squeeze out some bilirubin from people by binding that. But in general, what we try to do is we try to decrease the production of free hemoglobin to block bilirubin production in people. High unconjugated bilirubin in little babies, that causes that problem called icterus, where little babies get yellow. And that can happen in little babies as a result of the mother's immune system attacking the baby's blood cells. That's, again, more than we need to talk about in this context. But in most people, high bilirubin is not dangerous. It just can be indicative of liver disease. Some patients with PNH will have a high bilirubin because either they have ongoing hemolysis, because their complement system is not adequately blocked, or because there is destruction of the red cells in the liver and the spleen through what we call the reticuloendothelial system, and we can sometimes see hyperbilirubinemia in that context.
Thank you. This question is in regards to blood transfusions. A patient was having blood transfusions about once a month, and her iron was going up. She was put on Jade, but it drastically lowered her platelets critically to the point where they took her off. Is there another form of treatment for reducing high levels of iron from transfusions?
Yeah, so iron chelators, oral iron chelators are relatively new to the scene. For many, many years, the only iron chelator that was available was a drug called desferal, which is a subcutaneous injection, usually given over the course of 8 hours. So Jade or desferoxamine is an oral formulation. There are other drugs, defirapone, and other drugs that are used in the thalassemias, which are approved. They also have some problems with low blood counts and kidney dysfunction. The oldest drug, and in my experience, the most reliable drug that I use for people is actually desferal, which is a very ancient drug given subcutaneously or intravenously over 8 hours, 5 days a week, and has been very effective for a lot of people with inherited problems with red cell handling, like thalassemia. That's another alternative. If Jade doesn't work for you, the desferal is often something that I like to use. And it's old, it's well characterized, and it doesn't have as many problems. Still problems with the hearing, the high frequency hearing testing needs to be done, and the cataracts should still be done, but not as many problems with low blood counts. And not as toxic for the kidney either.
Thank you. Our next question reads, this individual read that radiation and benzene are potential causes of stem cell damage and may cause PNH. Do you have any information on this?
Yeah, so our bone marrow stem cells live with us our whole life. Those stem cells are relatively protected from DNA damaging agents because they don't divide that often, right? DNA damaging agents usually cause damage during the process of cell division when the cells are turning over. Benzene and radiation can damage stem cells that are not dividing. And they do that by causing crosslinks in the DNA. And so you can have a stem cell that's sitting there minding its own business, gets exposed to radiation. Maybe it doesn't get called up to divide for many years, 2, 3, 4, 10, 20 years. As we age, the stem cell pool, remember I told you we started out with all these seeds, we lose about 1% of our seeds in the bone marrow stem cell compartment per year. As we age, the pool of stem cells from which to choose decreases. And so the potential that once you've been exposed to a radiation or a benzene in the course of your lifetime, the chance that a stem cell that was damaged by some exposure like that might be called up to divide is higher. We know that associated with normal aging in humans, we see acquisition of mutational events. So turns out that human beings, when they're born, generally do not have mutations in the blood. But with every decade of age, we see an increase in the number of people who have these mutational events, different types of mutations, but bottom line is that similar mutational spectrum to what we see in people with blood cancers, mostly at a very low level, right? Less than 2% of the total bone marrow population when we think about clones, right? So these are very small clones, but we see them with increasing frequency with aging. By the time we get to be 70, 80, 90 years old, as many as 20% of normal people with normal blood counts and no leukemia or no blood cancer diagnosis will have mutations that are detectable at a low level in the blood. So small clones, maybe 1%, maybe 0.5%, but those mutational events speak to the fact that any exposures we sustain over our lifetime can damage the stem cells. And yes, benzene, radiation, if you x-rayed your feet when you were a kid in the Buster Brown shoes, if you refinished a piece of furniture with a volatile organic compound based something, if you inhaled a lot of car exhaust, any of these things that are potentially damaging could have damaged the stem cell. I don't know if that answers the question. Those are exposures or risks that are known to occur. But they don't guarantee a diagnosis of cancer. We know that people who survived Hiroshima and Nagasaki, they have an increased risk of MDS and of bone marrow clonal disorders. PNH happens less frequently in those people than, for example, MDS, but can also happen as a mutational event that is an acquired event.
Thank you. If hemoglobin decreases even with treatment, does that mean the treatment is not working, or can a patient expect variations?
So remember that your red cells are made new every 3 months. So your bone marrow is continuously ticking over, making new red cells all the time. And so you can see variations in the red cell numbers or the hemoglobin over time based on the time of year. So in the winter, when there are lots of viral infections, complement may be more active than it is in the summer. If you have a stress event, complement can be activated and can overcome the block that is instilled by treatment. Once I give a drug intravenously, I get a certain level of drug in the blood. But if I have a complement activating condition, surgery, stress, you get really cold all of a sudden, you get soaked in the rain, somebody in your family dies, all of those things can activate the complement system to kind of protect you. It gets revved up to protect you. And if you have a certain amount of drug in the blood and your complement levels go up above the threshold where you exceed the amount of that drug that's around to act as a sop, like it's almost like a sponge for that complement. And if you just don't have enough sponges to block the complement, you can see a breakthrough of hemolysis and breakthrough of the inhibition. And then in that context, people can become newly anemic. I have had a lot of situations where I have patients with young kids who tell me, every year in the winter, I just get virus after virus and my hemoglobin is always lower in the winter and there's nothing I can do about it. And then in the summer, the hemoglobin comes up and they feel better. And it's probably because they get, again, virus after virus and they have an episode. The hemoglobin, again, can vary widely over the course of the year, over the course of time. And just because one might need a transfusion doesn't necessarily mean that the treatment isn't working. One caveat to that is that sometimes if people are becoming progressively more anemic, you worry that the bone marrow stem cell problem or the bone marrow failure problem might be getting worse. And so in some cases where I have a patient who has a PNH, but also a component of maybe moderate or mild aplastic anemia, I watch the counts, and if I see that the blood counts are falling or that the hemoglobin has changed, I would consider repeating a bone marrow biopsy to make sure that the aplastic anemia or the MDS is not behaving badly or getting worse. Because in that case, I would think about treating the aplastic anemia either with a growth factor like eltrombopag or with, again, ATG cyclosporin, eltrombopag, or some combination of those things. And that happens sometimes over time. You know, you see the T-cell attack increases and you have to treat that again.
How common are partial responders to the current PNH treatments that are available, and what other options exist?
Partial responders. Well, so the current treatments that are available, eculizumab, ravulizumab, and then the new drug, the APL-246, APL-2 drug, which I don't know if it's actually available yet. I haven't been able to write it for anybody yet. I don't think they've made it yet, but they don't have it clinically available yet. But those drugs, they generally are very effective at doing a couple of things. They markedly decrease the rates of blood clots. So in the old days, people with PNH had terrible effect on life expectancy that was mediated by recurrent blood clots. And recurrent thromboembolic events actually caused a majority of the early deaths that we saw in patients with PNH. Retrospective assessment of survival in people with PNH who are receiving eculizumab has shown almost normalization of survival curves in those patients. And so the effect of thrombotic events on survival has been markedly altered by the availability of C5 inhibition for patients with PNH. And so I think that's been a huge benefit. Many patients with PNH who have had a blood clot who receive eculizumab are actually able to come off anticoagulation and don't have recurrent thrombosis. In the context of breakthrough hemolytic crisis, so if you have new worsening of anemia, if you have a complement activating condition, there can be a breakthrough hemolytic event, which then precipitates a thrombotic event, which requires anticoagulation for a period of time. But overall, the use of eculizumab and of C5 inhibition has really changed the frequency and the severity of thrombotic events in people with PNH. Many people with PNH, despite being on eculizumab or ravulizumab, will still have some degree of transfusion need or anemia. And that can be a problem and probably speaks to the component of the bone marrow failure disorder and potentially to the inadequacy of C5 blockade to block extramedullary or extravascular destruction of red cells. So during the process of the complement system activation, the early part of the cascade results in deposition of a molecule called C3 on the surface of the cells that are missing those inhibitory proteins. C3 kind of sticks to the surface and makes those cells more attractive to the reticuloendothelial system, the spleen and the liver. And so the spleen and the liver see things that have C3 sticking to the surface, and they gobble them up. And that's called hemolysis in the reticuloendothelial system, right? Extravascular hemolysis. Extravascular hemolysis is more likely to cause elevation in the bilirubin. It certainly is something we do see in people with PNH, not as often necessarily as we see intravascular hemolysis, but certainly we recognize that as a component. So for people who are on C5 inhibition and who have elevated bilirubin, who still are still making a large number of reticulocytes, so their bone marrow is still having to work really, really hard to maintain adequate hematopoiesis, inhibition at an earlier stage of the complement system by blocking C3 might be of benefit and might improve the hemoglobin. Essentially what it does is it de-stresses the bone marrow system. So if your bone marrow system is already relatively weak, and it's working as hard as it can to make new red cells, white cells, and platelets, if you take the stress off by letting those cells that it does make live a little bit longer, then the amount of hemoglobin that you have in circulation, or the number of red cells, the number of platelets, number of white cells, might actually be better. Does that make sense? So yes, there are partial responses. I think the question really is a little bit nuanced in the sense that the responses in terms of blood clotting are pretty substantial, even with the currently readily available standard of care approaches that target C5. The degree of anemia, thrombocytopenia, could be perhaps improved with an earlier blockade of the complement system, and might improve response in terms of the hemoglobin response.
How does APL-246 differ from Soliris or Ultomiris, and can you take the two drugs at the same time, and what are the side effects?
So ask me the question again. How do the two drugs differ?
Yes, how does APL-246 differ from, say, Ultomiris, and what are the side effects of APL-246?
So the APL-2 drug is a C3 inhibitor, okay? So it blocks earlier in the pathway, and it can block the extravascular hemolytic process. That drug was just tested in a study in which they gave patients who were already on eculizumab, started the C3 inhibitor at the same time that they stayed on eculizumab. And then after being a month on both drugs, they crossed over to just get the APL-2 drug. The drug was approved because of the improvement in hemoglobin in the patients who crossed over. And most of the patients who were on that study were having an inadequate response to their primary drug. And they were on eculizumab. All of them were on eculizumab, because that was the inclusion criteria for the study. The study showed superiority for the APL-2 drug in terms of improvements in hemoglobin and anemia, and improved quality of life. I haven't seen the final publication yet, but certainly it looks like a very promising addition to the armamentarium, particularly in people who are having an inadequate response or incomplete response to eculizumab. We don't have very much long-term follow-up on that study, but it certainly looks very, very promising. The question really is, that drug is given subcutaneously. It's a relatively large volume infusion. It's given twice a week. Some people are a little bit more anxious about that. We'll have to see how that shakes out. Eculizumab and ravulizumab are humanized monoclonal antibodies that include some mouse parts, mouse antibody that is humanized to be more like a human antibody. Both drugs bind to C5 and inhibit the function of C5. So APL-2 drug inhibits C3, which is upstream. Ecu and ravulizumab inhibit C5, and they essentially act as a sop for C5, like a sponge for C5. Same kind of concept for the APL-2 drug, sponge for C3 instead of C5. Theoretically, there could be more immune defects in people with getting a C3 drug versus a C5 drug. That has not really shown to be the case as much in the studies, at least that I've seen. And again, patients should be appropriately vaccinated to protect them against encapsulated bacteria, particularly meningococcus and gonococcus. We don't have a vaccine against gonococcus, but should be aware of the risk of gonococcus. So those vaccinations are required as part of the pre-evaluation. Now, I also tell my patients that it's reasonable and rational to consider getting vaccinated also for pneumococcus and for other vaccines, because many patients with aplastic anemia have a suboptimal response to vaccination with various agents, and any kind of infectious process can enhance complement production and thereby precipitate a hemolytic crisis in patients with PNH. And so I tend to be very thoughtful about with my patients. I talk about with them adequate response to vaccine. Documenting adequacy of response to vaccine is an important aspect of that. And if they have not adequately responded to vaccine, I think about putting people on prophylactic antibiotics, either with penicillin, which is what they do in England, or giving people antibiotics to have in the event that they have a fever, so they can take it right away without waiting.
Thank you. Is there any indication that PNH or aplastic anemia can self-resolve over time?
That's a really interesting question. And there have been serial evaluations of patients who had originally had aplastic anemia, received treatment for their aplastic anemia, develop a PNH clone, and then over time, actually that clone size decreases and goes away. And so one of the things that I do routinely in my patients who have aplastic anemia is I serially follow their clone size over time. I have had one patient whose clone disappeared or diminished to the extent that they were not affected by substantial intravascular hemolysis, and they were able to come off drug because their clone disappeared over time. And you can appreciate the reason that might be the case is if their stem cell pool expanded and normal stem cells came back, and that PNH clone became a less dominant player. Now that their aplastic anemia was gone, the normal stem cells took over. And hopefully that stem cell clone is not going to come back.
Thank you. Is it possible for a patient with PNH to get cancer, such as leukemia, if there is a family history of leukemia?
So patients with aplastic anemia or MDS who have PNH clones are at risk for developing secondary leukemias. We certainly know that patients who have history of bone marrow failure states, the stem cell pool is diminished. And so the risk that there might be a damaged clone within those clones that survive the attack on the bone marrow is higher. We certainly know that people with aplastic anemia and PNH who had the disease as younger people, over time, those people seem to have an increased risk of developing leukemia. That's one of the reasons why very young people who have new diagnosis of aplastic anemia are offered allogeneic bone marrow transplant as a first choice if they have a good match sibling donor or if they have a good unrelated donor, because it seems as though that decreases the risk that a secondary leukemia might occur. In people who have a family history of leukemia, that is an interesting and I think an evolving area of question. When I have a patient who has newly diagnosed aplastic anemia, one of the things I'm always asking is this acquired aplastic anemia mediated by an immune attack on the bone marrow, excuse me, or, sorry, allergies, or is this a bone marrow failure state that is mediated by a genetic event? So we know that people who have bone marrow failure can have that bone marrow failure as a result of inherited bone marrow failure gene mutational events. And so if I have a young person who presents with PNH, who presents with aplastic anemia, I almost always send them for genetic counseling, and we almost always test them for germline events in TERK and TERT, dyskeratosis congenita, in Fanconi gene mutational events, and in a whole series of other inherited bone marrow failure disorders, which can look a lot like acquired aplastic anemia. Most of those people do not have PNH clones, in my experience, and they're more likely to have mutational events if you do mutational profiling. But it is always the case that when I have a new patient presenting with aplastic anemia or with what looks like bone marrow failure, it is important to consider whether there is a family history of malignancy, whether they have any syndromic features associated with any of these inherited bone marrow failure states, or whether or not they have anything that makes me think that they might have a congenital or a germline in the skin in every cell in their body event that predisposes them to develop the bone marrow failure state.
Thank you. This question comes from a patient who is currently using APL2. They now have acquired RA. Is this typical with PNH patients, or are they just lucky?
Well, that's a personal question about your medical history. I don't know. I guess I would say that's probably unusual. It's certainly not something I've seen routinely. It's not been reported. Again, I don't have extensive experience with APL2. It's a relatively new drug. I don't think we have long-term follow-up to suggest, but based on the mechanism of the drug, you wouldn't really expect it to be the case. But we know that aplastic anemia is like an autoimmune disease, so it's not out of the realm of the possible that this could be again, a manifestation of the autoimmune background, the genetic predisposition for autoimmune disease. So just lucky. Sorry. Probably.
How do patients decide which PNH treatment to use, whether they start Ultramarys or Soliris, or even go to a bone marrow transplant?
So this is a question that should be addressed in consultation with your doctor. For me, when I start thinking about a patient who has a new diagnosis of bone marrow failure or of inadequate hematopoiesis, the question is really, what is the most prominent symptom of the process? Is it hemolysis? Is it a blood clot that's life-threatening? If it's a blood clot or really hemolysis, that's the driving feature of the disease, and the bone marrow is not particularly hypocellular and the patient has not got neutropenia, you would consider treating the PNH as the primary focus of the disease. If the patient has more of a bone marrow failure state with a low neutrophil count, a low reticulocyte count, and a low hypocellular bone marrow, I would think seriously about starting with the immunosuppression. In terms of a patient who has true clinical PNH with some feature that shows evidence of end organ damage, blood clot, kidney dysfunction, pulmonary hypertension, something like that, that pushes, or a large clone with active hemolysis, needing transfusions, or even not needing transfusions, but very fatigued and with a high LDH, in these patients where I'm trying to choose a new drug, I talk to patients about the different options that are available. I generally start with drugs in the C5 inhibitor class, either eculizumab or ravulizumab. And I do that because those drugs have been around the longest. We have the longest safety profile. We also know that those drugs, certainly eculizumab, has shown a substantial improvement in the risk of blood clots. I think for most patients, they probably would prefer to start with ravulizumab. Ravulizumab is the longer acting formulation of the eculizumab drug, which is altered in the sense that it's recycled into circulation, and so it lasts for 2 months instead of having to be given every 2 weeks. Ecu has to be given every 2 weeks. And many patients on the studies of ravulizumab had much better control of C5 levels and blockade of C5 on ravulizumab. And it's easier to give because it's really it's after a loading sequence, it's every 2 months, and it's much, much faster and easier for people. You have to go in over a longer period of time. So ecu, it's a 30-minute infusion. Ravulizumab takes several hours, but it's only every 8 weeks instead of every 2 weeks. And so many people prefer to start with ravulizumab. For me, these are the functional end of the molecule is the same. It's just the duration or the pharmacokinetics of the molecule are different. One hangs around longer than the other because it's recycled as opposed to killed by the system and taken out of circulation. I have not, up to this point, started any patients on APL as the first line therapy. I think I would like to see a little bit more time, really, for safety information. It's an earlier time point of inhibition of the complement system. Certainly, it's a great drug for people who are not adequately controlled on ravulizumab or eculizumab. I think that's a great option. And I think as we develop more experience with that drug, certainly the hemoglobins have been higher. It looks very, very promising. I just think it's relatively new. And so right now, I would generally start probably with most people ravulizumab based on the convenience and the less frequency of infusion. Or if they prefer eculizumab because they want to get the infusions at home or for some other reason, eculizumab.
Dr. Griffiths, our last question for the evening, does Soliris help with low platelets?
So again, we're about to get cut off here, I think abruptly in 1 minute, but low platelets sometimes can be helped with these drugs that block complement activation, because again, platelets are being attacked by the complement system just as the red cells are. It's just that they are able to survive a little longer. So sometimes you can see an improvement in the platelet count, although the original studies were not designed to look at that. And we don't have like clear pictures of that the same way we do with the data with red cell improvements. Certainly though, you do have less attack of the platelet compartment when you give ecu or rav, and you also take the stress off the bone marrow compartment, which might make the rest of hematopoiesis more at ease and make it more effective.
Cool. Thank you so much, Dr. Griffiths, for sharing your time and your expertise with all of us this evening. If you'd like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. If we were not able to get to your question or you have a question after the webinar, please send it to us in 3 ways. Send an email to help@aamds.org, call our helpline at 800-747-2820, extension 2, or submit a question on our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us and making us your resource of choice on information on bone marrow failure diseases. Our medical advisory board and team are here to support you and your family as we have done for the past 36 years. This concludes today's program. Thank you, Dr. Griffiths.
Thank you all for listening. I hope I wasn't too complicated or too abstruse here, but thank you very much. Excellent questions.